rhythms. Can we still remember it? Is somebody typing? So while I'm expecting a response, let me continue. I hope we still remember the unending capital W of supraventricular tachycardia. I hope we remember continuous small n of ventricular tachycardia or small m, but continuous. I hope we remember shapeless of ventricular fibrillation. I hope we remember flat line of asystole. There's one more I forgot to add. I will talk about it next class because I still did not add it. Pulseless electrical activity, PEA. So in next class, I'm going to talk about it. So it's also ventricular problem. I hope you remember that when you have ventricular tachycardia, what's the first thing you will do? Second question. The first one you've not responded, I added another one. So when you look at your strip and you see that continuous hem, whether it is monomorphic or something that looks like going up and down, and also like N, but not a fixed shape, polymorphic. By the time we see either of them, what should you do for this patient first? Second question. You can answer here, you can answer on WhatsApp. I'm going to say it. Okay. Then I hope you remember the twisting torsa. The twisting torsa. Now, how will you not be able to identify any graph? How? They are not sounding alike. The torsa that twists. Then, and I hope you remember that the first thing to be done is what? Assessment. The assessment may cover lab value, the assessment may cover vital signs, but most of the time in torsa that is twisting, you see potassium, you see magnesium. Both of them can be the reason why torsa is twisting, but please give magnesium, not potassium in this situation. In the U-wave appearance, you give potassium. Do you understand to this level? So let's go to today's, and the flat line asystole, just someone that is like clinically dead. And I hope you remember I told you, except your question says that something has been done to a patient with ventricular fibrillation. Ventricular fibrillation comes first in every situation of ECG strip. Even if it's third degree heart block, even if it is third degree heart block, ventricular fibrillation comes first. But still, please take your time and look at your question. Okay? So let's go to tonight's class. Everybody welcome. And I hope you had a nice day. Apology that we had to add a 2-day break in the course of the study. Please just leave it like that. Just leave it like that. So we'll meet up with it, okay? So let's go to premature beats. Premature beat covers PAC, premature atrial contraction. Okay, I need you to, in your jotter, I'm sure many of us are jotting. You are not just looking at me, I'm sure now, you are jotting. So in your jotter, have a big head called premature beats. Have you done that? If you have done that, just say hi. Hi. Okay, so draw 2 arrow out. Bring out 2 arrow. There's a line above premature beats. One goes here, PAC. One comes here, PVC. Have you done that? Premature beats, number one. Number two, PAC. Number two, number two, PVC. Are you there? Once you are done with this, please let me know. Are you done? Now, under PVC, anyway, both of them. But if you are actually planning for NCLEX, it's basically known for PVC. So under PVC, you now bring another two lines. One is bigemini, the other is trigemini. If you are done with that diagrammatic sketch, please just say hi so we continue. Thank you, Nosoluchi. Who else is done? Who else is done? Nosebere did not join class today. Where is she? Okay, thank you. So let me share my screen so that you can see how it looks like. I should repeat the sketch. Okay. The big head is, or the big heading is premature beats. The big heading of the sketch is premature beats. Can you see my screen? Okay, let me follow from here so that I won't be asking you. Few minutes. The big heading is premature beats. You will now bring it into two places. It can be premature atrial contraction. It can be premature ventricular contraction. I said that both of them can be affected with premature beats. I said that both of them can be affected with premature beats. But if actually for the exam, please make another two line under premature ventricular contraction, meaning bigemini 1, trigemini 2. So are you done with the sketching? Have you sketched? A dish heads. Oh yeah, let me hear if you are good before I continue to go. Okay, so I believe everybody can see my screen, and this is where we are starting from today. Premature beats. It can occur in the ventricle, like I said. So when it occurs in the ventricle, it is called PVC, premature ventricular contraction. Okay, and when it is occurred in the atria, the two of them, it will be called premature ventricular atrial contraction. Now, what are premature beats? These are extra beats. You know, we have learned PQRST, meaning that on a particular graph, what you want to see is 3 elevations. On a particular graph, what you want to see is 3 elevations: the T, the QRS, the P, the QRS, the T. But by the time your graph is coming with extra bridge, then you might begin to think of premature beats. This bridge may go up if it's atrial, it might come down if it's ventricle. I'm going to show us in a jiffy. So they are extra, they are abnormal, and they briefly disrupt the heart rhythm. It's not something that should stay for long. In fact, many people have it occasionally, even in a healthy diet. Sometimes when you run too much, sometimes when you take hot caffeine, these are things that can make you to have premature beats. It's It's not something to freak about. And I'm going to tell us when we should freak about it. Okay? Now, this is PAC. This is PAC. PAC, like I've explained, occur in the atria, and that is the upper chambers of the heart. The patient may just feel mild palpitation, or you might just feel like, I'm not feeling like my heart is beating continuously. And you can see the trigger, the fatigue, stress, caffeine, alcohol, and dehydration. These are the triggers. Okay. But please note, they are usually benign. In fact, it's not what we bring to the patient to the hospital. No, it might not bring the patient to the hospital, because it will just come, and in no time the patient will be fine. So most times it is you see it when the patient is to do some other routine test. Okay. And like I said, I'm going to distinguish to us so that we know when we freak about it, and when there's no need to freak about it. Are we good? Few minutes. So that's PAC. See the diagram. See the diagram of PAC. Now look at the normal sinus reading. Please, if you can see the normal sinus reading here, just say hi. If you can see the normal sinus reading here, just say hi. Let me see our hi. I can see the normal sinus reading. Say hi. If you can see the normal sinus reading up here, leave the graph now. We are talking about, leave the lines. We are talking about the raisins. You can see the three raisins I'm talking about: the P wave, the QRS, the T. This is the one up here. As you can see, my cursor moving it is the normal sinus reading. This is now the PAC, premature atrial contraction. This is now the what? PAC, which is what? Premature atrial contraction. You can see this is the normal P. This is the normal P. See the abnormal P. How many people can see what I'm talking about? Thank you for your responses. See the abnormal P here. You can see where my cursor is moving. You can see that this is not raised like this and this. This jump down. Now, the main P is still there. The main P, this is still the main P. You can see that my green cursor. This is still the normal P. But this one that is depressed is what? Is the premature. Meaning that there are two P's here that give a shape of V before joining the normal P. Please, how many people can see what I've just explained? If you can see what I've just explained, just say yes. Or if you could see what I've just explained, just say yes. I've explained something now, and if you could see it, just say yes. Okay, thank you. I expect more responses, please. So that is the premature atrial contraction. Now we go to, so this is how you see it. You see it's not continuous. The next beat, the heart has its normal P again. Yeah. So it's not something that is continuous. The heart will just have it and readjust. So this is PAC. Now let's talk about PVC. PVC is that type that most times NCLEX can freak for. NCLEX can freak for. You know why? Because of the bigeminy and trigeminy. because of the bigeminy and what? And trigeminy. Now, what is PVC? PVC is that abnormal too and premature. It occurs at the ventricles. You know, the other one, the patient feels something like palpitation. This one, the patient feel a kind of thump or a strong beat. You might just feel, you know, you will feel it. This one, the patient will feel it. Okay? Or you say, my heart skip. My heart skip. Ehen. So it's almost the same thing that causes it. But you see this one, this is why NCLEX will look at it more. Smoking and electrolyte imbalance. Because of the smoking and the electrolyte imbalance, NCLEX will look at it the more. Now, there are two types of them, either bigeminy or trigeminy, just like I've explained. Now, before I show you the diagram, or let me show us the diagram so that I won't waste much time. Before I show you the diagram, what happened in bi? You know, bi mean two. Abi, bi mean two. It now mean that there is normal QRS. The next one will be premature QRS. Let's say you have 10 QRS. Number one is normal QRS. Number two is premature QRS. Number three is normal QRS. Number four is premature QRS. Number five is normal QRS. Number six is premature QRS. And that is why it will continue. So where the bi is being played out is every second beat is a premature. Where the bi is being played out is every second beat is a what? Is a premature. For the trigeminy, 3. Let's say you have 10 in a row. The first one is normal PQRS, that's normal rhythm. The second one will be normal PQRS. The third one will be premature. Okay? The fourth one will be normal. The fifth one will be normal. The sixth one will be premature. The seventh one will be normal. The eighth one will be normal. The ninth one will be premature. Okay? That makes it every third beat. That's the meaning of the big English you are seeing there. Bigeminy, every second beat. Trigeminy, every third beat. Let me now ask us a question. Who among these two has tendency for a higher occurrences of premature contraction? Is it bigeminy or trigeminy? Who among them? I'm expecting us to reply, please, so that I'll be sure you are following me and you are getting it. Where are we? Oh, are we still here? Can you still hear me? I think yes. Bye. Okay. Nurse Latifat said bye. Okay. Nurse Oluwakemi said bye. More responses, please. So out of that 10, a patient with bigeminy will have 5 abnormal beats by. Why a patient with trigeminy will have 3 abnormal beats. So if you are to prioritize, who would you prioritize? If you are to prioritize out of these two, who would you prioritize? By. You see, it's not difficult. It's not difficult. Just knowing those big words around it and you're good to go. Okay, so let's go to the diagram. This is bigeminy. Have you seen one PQRS, This is PVC. You see this thing that drop, just like the way atria dropped. This is PVC. This is PVC. This is PVC. And you can see it occurring every after one normal QRS. One thing you will know about PVC is it produces a bizarre QRS. One thing you know about PVC is just like ventricular tachycardia, it makes the QRS to be wide. That's what I mean by bizarre. Like instead of 1 to 2 boxes, I'm seeing like 1, 2, 3, 4, 5 here. Instead of 1 to 2 boxes, you're having 5 here. This is 5, and this premature is covering almost 8. So you need to know that it produced a bizarre P wave. So let's imagine they didn't even give graph. They just say the patient, um, you're a telemetry nurse, you observe that your patient that is having that is on a continuous monitoring is having alternate wide QRS. That's by Gemini they are explaining. Okay, I hope we are good. Now this is trigemini. I've explained everything in this note too. So you can see 1, 2 abnormal, 1, 2 abnormal, 1, 2 abnormal, 1, 2 abnormal. Is this it? Do we have any question on this? This is all about trigemini and bigemini. What you do first is to assess your patient. Then you might need to assess the lab values. Okay? Assess the patient, assess the lab value. You don't freak until you have 6 PVCs. As it is now, if your question gives you this graph and asks you what you should do, the best thing to be done is just document and continue to monitor the patient. Why? This is just 2. But when you have a graph with more than 6 PVCs, you have to do what? Okay, sorry, let me take a word back there. Your question gives you this, and they ask what to do. If the assessment of vital signs is there, assessment will be okay, just to check the patient. If assessment of vital signs is not there, and you are seeing something like give potassium, repetition, document, please just document. But if there's documentation and there's assessment, please assess. Are you seeing how to filter these options? So that's why I said, let me take it back. But once it is 6, please, you have to notify HCP. Okay? Are we good? Let's go to paced rhythms. Paced rhythm, paced, like pacemaker. When a patient is wearing a pacemaker, there's a way the patient's ECG will look like. That's an experienced telemetry nurse will say, oh, you have a pacemaker, and the patient will say yes. A paced rhythm is the heart rhythm that occurs when the heartbeat is controlled by artificial cardiac pacemaker. Like the SA node cannot initiate the impulses again. So the patient is wearing a pacemaker. Okay. So how will it look? You will see spike. They call it pacer spikes. The telltale sign of a pace rhythm on an ECG is a straight vertical line called pacer spike. Let me show you. This is the spike. Oh, let's go and see another one. You see it in your notes. Just hold on. See the spike here. See the spike. See the spike. See the spike. How many people can see it? You see that one line thing? This is atrial paste. This is ventricular paste. This is atrial and ventricular paste. Alpha. Are we good? So when somebody is wearing a pacemaker, you will see this spike like this. spike like this on their ECG. Okay, so there are three types. Just like you see it here, there are three types. It might be atrial paste. Atrial paste means the ECG is set to um, perform the work of a SA node. Like, is this pacemaker that will initiate the impulse. So you will see this spike before the P wave. If you can remember that I told you that P wave is the happening of the upper chambers of the heart, and you are saying atrial paste, so you expect that spike to be behind the P wave, because these spikes occur that P wave can come. If this spike does not come first, this P wave will be missing. Let me say it another way. It's because naturally the heart cannot bring up this P wave. That is why you are having this spike. So the appearance of this P wave depends on this spike. So you have to see it behind the P wave. Once you see it like this, is atrial paste. On the other hand, it can be ventricular paste. Like maybe it is placed at the level where you just want it to respond, you just want the ventricle to respond to it, maybe at the AV node area. Okay, now the spike precedes the QRA complex, lower chamber is stimulated. You can see that. So you, just like I explained the ventricle, you will now see it behind QRS. You see, because it's this spike that bring about the QRS you are seeing here. Then this is an example of dual paste, dual chamber paste. So you see spike before atria, you see spike before ventricle. Then you know this is they paste the atrium, they paste the ventricle, dual paste rhythm. That's all about paste rhythm. Who has question? Who did not get it? Are we okay? Before we go to their abnormalities, does this make sense to us? Do you have any question at all? Can we talk about it? Why are you not liking these figures we are talking about? Eh? Can we talk about it? Any question? None? Okay. So let's go to paste rhythm abnormalities. There are three specific abnormalities that can occur in paste rhythm. Normally, I didn't show us how a continuous ECG of a paced rhythm should look like. I didn't show us. Let me quickly go and look for it. Sorry. So if it's atrial paced, it's continuous like that. You keep seeing one spike before the atrium. If it's ventricular paced, it's continuous like that. You keep seeing one spike before the ventricle. And if it is dual paced, you keep seeing it together like that. Okay. Okay. So the three problems that could occur with paced reading, one is failure to sense. Is what? Failure to sense. The second is failure to pace. The third one is failure to capture. Failure to sense, failure to pace, failure to capture. What is failure to sense? The pacemaker that is installed or that is placed in the heart, it fails to detect the heart's own natural beat. Like you now see the pacemaker, it doesn't wait to deliver at the right time. It just fires in appropriately, and it will not cause the that spike, eh? That spike that's supposed to be behind either of the paced area. If it's atrial paced, it's supposed to be behind P. If it's ventricular paced, it's supposed to be behind the QRS. Okay, you will not see that spike staying on top of the natural beats. Like instead of staying behind it, you will now be staying right on top or in front. Look at it. Look at it. This is like this is QRS. This one is ventricular paced. This one is supposed to be ventricular paced. You can see where it is. Now, see where you have seen one ventricle here. I should have even used a closer diagram. Sorry. You have seen one ventricle here. The P as follow. This is missing. So in failure to sense, the best way to know it is that you have more spike. You have more spike than the number of what is to paste. Like, okay, let's count these ventricles now. 1, 2, 1, 2, 3, 4, 5, 6, 7, 8. So let's count the number of spike. 1, 2, 3. There is more spike. Okay, 1. Few minutes, please. So with failure to sense, there will be more of what to be sensed, sorry, than the spike. There will be more of what to be sensed than the spike, and usually is dislodgement. There will be more of what to be sensed. If it is P wave that is to be sensed, it will be more than the spike. Please, I want to get us a clearer diagram. That looks like 12 lead ECG, and that's why it's looking confused. Let me get us a clearer diagram, then we'll understand better. Okay, so while it's downloading, let's go. I will come back to it. Now, next one is failure to capture. This one now, the heart, the pacemaker is sensing. This one now, the pacemaker is sensing. But the heart is not responding. This one now, the pacemaker, failure to capture, the pacemaker is sensing, but the heart is not what? Is not responding. Most likely because the impulse is not too strong enough to cause the heart muscle to contract. So it is in this place that you will have more of spike. Please don't correct it. It is in this place, it is in capture, you have more of spike because there's a spike or there are spikes, but the heart is not responding. So it is in failure to capture, you should have more number of spike than the what is spiking. So if this is to spike or this is to spike QRS, okay, you can see we only have 2 QRS here, but we have 1, 2, 3 spikes, meaning that 1 QRS is missing. So it is in, just say that failure to capture you have more spike than what is to pace. I use what is to pace because it might be atrial, it might be ventricle. In failure to capture, you have more spike than what it is to pace. The reason is because the pacemaker is sending out impulses, but maybe the impulse is weak, so the heart is not responding to that impulse. Meanwhile, because the pacemaker has sent it out, you will see it on the ECG. Because the pacemaker has sent it out, you will see it register just like this one now. This is a spike. However, is lacking the QRS. That is failure to capture. Okay, this thing is not saying. With failure to pace, third one, with failure to pace, what happen here is pacemaker is not even pacing. In failure to pace, pacemaker is not even pacing. The pacemaker fails to generate an electrical impulses. And why you put pacemaker is because the patient is most likely having bradycardia. So it's expected that as the pacemaker senses that bradycardia, it will increase the impulse so that the heart rate can continue. However, with failure to pace, the pacemaker is not responding. So we can say that failure to pace is pacemaker problem, failure to sense and failure to capture is intrinsic, like heart problem. It's heart that is not responding. Pace is pacemaker that is not responding. So what will now happen? It will now make you to have a heart rate that is so slow with long pauses. You'll be having something like pain per, you are counting heart pulse. Heart rate per, you know, unnecessarily long, because the pacemaker that's supposed to work is not working. What will now happen here? You will now have more number of what is to be paced than the pacemaker. What will happen here is the number, see here now, there's no spike. Spike is missing here. Spike is missing here. This is supposed to be ventricular spike. See where it is. The first thing you need to do in this situation is you need to know that is this ventricular paced or is this atrial paced? And it's no more difficult where you see that spike. Behind where did you see that spike? Behind QRS, as we're seeing it, this is ventricular paced. Now you can see the failure to pace here. So as there is no spike, there's no wave, there's no QRS wave, because so you now see you see where that long pause will occur. Alpha, why is the word is not facing down? What do you mean by word? WORD, no Zainab. It's not, is it facing down at your side? No. Like it's turned upside down, Abi. Do you mean that it's turned upside down or what? It's not facing down, it's facing up. So any question on these abnormalities? Failure to pace, failure to sense, failure to capture. Any question on the other one we've mentioned? The last thing we're going to do tomorrow is the 3 art blocks or the 4 art blocks. That's all. For all this failure of whatever, the best thing you would do for this patient is to, especially if the patient is showing symptoms, you do transcutaneous pacing. Transcutaneous pacing. It simply means that what the patient is wearing as we speak cannot rescue the patient. So you have to bring external gadgets to keep the patient alive. Atropine may not help because the bradycardia that the patient is having is because of structural abnormality of the heart. Okay. So atropine may not help this patient. So if you see the option of atropine in a patient whose history says is wearing a pacemaker, please, and you see the option of transcutaneous or external pacing, some diagram comes like that, 6. So, and you see the transcutaneous or external pacing, please, the option here is not atropine o. This is not bradycardia or vagus problem. This is bradycardia of heart structure not being able to respond. So you have to pick the option that can make the heart structure to respond. Do we understand? Do we understand? What do you want me to talk about more? We are done with tonight's work. Oh. We're actually done with tonight's work. But I will change this diagram so that I can give us the one that we be more understanding to us. Okay, I will change it. So anything you want me to talk about again? So if you have this type of problem, failure to sense, you will not be able to say this is atrial or this is ventricular pace. The reason is because the pacemaker is just sending out impulses anyhow. He put it anyhow. That's one thing you will use to recognize it. Just look at this one now. You can see this one clearly before the ventricle, meaning this is ventricular pace. Abi? Okay. Let's look at this one. You can also see this one clearly before the ventricles, meaning it's also ventricular pace. Meaning it is also ventricular pace. You understand? But you see, under sensing, you might not really know, is it ventricle, is it pulse, because e just give out impulses. It doesn't wait for the heart to do its natural. It's not that heart is not dead, it can still work. But with under sensing, it does not wait for the intrinsic activity of the heart to occur. It just fire anywhere. So it can be under artery, it can be on, it can be with P, it can be with QRS, just anywhere. You understand? So we are done with the tonight's work, except if you have any other question for me. So let me ask us a question. The paced rhythm, is it going to be regular or irregular? Not paced. PVC, sorry. In PVC, premature beats. In premature beats, do you expect the ECG to be regular or irregular? Premature beats. Is the ECG expected to be regular or irregular? So who is responding? Where are we? Hello. Thank you, ma. I ask a question, you have not responded. Okay, it's irregular beats. Wow. Why do you think it's irregular beats, ma? Why do you think it's irregular beats, ma? So I can remove this. The rhythm is naturally regular, but once this thing occur, premature beat it occur, it causes problem with regularity and makes it an irregular rhythm. Look at this. You can see it's coming regular on its own. This one now, premature make it longer. This is premature artery. It makes it longer. So it's supposed to be the regular, but once premature occur, the patient experience irregular rhythm. Okay, it might be regular later, but then as at that next beat is going to be irregular. Thank you, Nostiti. Thank you so much. If there's no question for me, then we can end the class. Did you learn anything? Thank you, Nurse Oluchi. Did you learn anything? You can see by Gemini. You can see that this looks regular, but at the level of PVC, there's no regularity. So it end up being an irregular reading. It's irregular. So did we learn anything? Look at PAC too. You can see that um it is irregular. Why? Because of the premature beat. So premature beats, PAC, PVC, they are irregular. So I think we're good. I think we can go. I have learned a lot. Thank you. Nostiti, were you in this class? Were you in this class, ma? I'm just seeing you, ma. Okay, so thank you so much. See you tomorrow. Let's and on Friday, I'll be here to take every question you may have on ECG. Every question. If I cannot answer, I will tell you. I'm not AI. I've just gone steps ahead. So if I cannot answer, I will just tell you. So if you are seeing it, for those of us preparing for NCLEX, so if you are seeing it in your question, just be keeping it for us till Friday. We'll be here to talk about them. Okay, there are still a lot, but what is needed for this level has been put together here, because they cannot we don't want to choke you. You are not a cardiologist, you are a nurse. Thank you so much. Thank you, and thank you for your understanding. We didn't call you for a free class and behave anyhow. It's just situation beyond my power. Please forgive. So we'll finish up on Friday. God bless you. Have a wonderful night. Bye for now. If you are watching this video, you have not subscribed, you are owing me a birthday gift. If you are watching this video, you have not subscribed, you are owing me a birthday gift. And don't just subscribe. If you have blessed, you bless your colleague too. Please help us to grow our page. We love you. Bye bye.